my honor to introduce Laurie and Desiree, who have a great presentation for you. Laurie Capovilla is a registered dietitian with a strong focus on the gut-brain axis, digestive health, and the evolving science of the human microbiome, particularly in relation to SIBO, IMO, IBS, IBD, and mental health. She earned her BSc with honors in dietetics from the Faculty of Medicine at the University of Montreal. Laurie currently serves as the International Development Manager for Dietetics and Continuing Education at Epithelia Pro, where she helps develop, write, coordinate, and deliver evidence-based nutrition education and conferences for healthcare professionals. She also supports individuals in private consultation with complex GI and systemic health concerns through her clinical nutrition practice. And our second speaker, Desiree Nielsen, is a plant-based registered dietitian in Vancouver, Canada, with over 15 years of experience. She's the founder of Desiree Nielsen Nutrition, a weight-neutral private practice and consulting firm with a focus on plant-based nutrition, digestive health, and perimenopausal and menopausal nutrition. Desiree is the author of 3 award-winning and Canadian best-selling cookbooks, Eat More Plants, Good for Your Gut, and Plant Magic. She is also the host of an evidence-informed wellness podcast, the All Sorts Podcast. In all of her work, she aims to create a positive, joyful space for living our healthiest lives without restrictions or rigid food rules. And with that, I'll pass it over to you, Laurie and Desiree.
Thank you. Desiree, do you want to share the presentation, please?
Oh, okay.
Thank you.
I thought it was sharing. Just wait. Okay, here we go. You know, all this experience, still Zoom newbies. There we go.
Perfect. Let's load in. Awesome. So if you can go to the slide, the 7th, please. The first slide, 2 more, please. Awesome. So the first case is about the dietetic management of a client with suspected SIBO. The client itself, next. Thank you. The client itself, so this is a copy paste of the reason of consultation I've had. So dietetics issue for several years. She's lost 50 pounds in a few months since her symptoms started. IBD, so inflammatory bowel disease, has been ruled out. She does have elevated inflammatory markers, especially calprotectin and CRP. She did have blood in her stool in the past, not at the moment. Uses Pentalog for GERD, and the gastroenterologist referred her nutrition after a diagnosis of IBS. The client is a pharmacist. She's a 30-year-old. She's pretty active, not really stressed. She works a lot, but she has time to sleep properly and exercise 3 times a week. But she has a lot of digestive symptoms. She's irritable all the time. She has chronic fatigue, a brain fog that just won't go away, and a loss of appetite. In terms of medication, she has the PPIs. She has no supplement, probiotics from time to time, but nothing really constant, and an oral contraceptive. In terms of GI symptoms, the first thing I want to know when I have a client with digestive issue is, when did everything start? What was the trigger point? In her case, after we started talking, we realized that she attended a wedding in 2018. And after that, she became pretty ill, started vomiting, had fever the first days. And ever since, the diarrhea never stopped. The bloating started as well and continued, and distension arrived eventually as well. So this is probably IBS, infectious IBS, so post-food poisoning, or we can already think it might also be a SIBO. Then when we get to question the digestive symptoms, she used to have this persistent abdominal pain, less intense as the day progresses, but passing a stool would not help reduce the pain, which is usually a red flag. She had this sensation of like a bar in the lower abdomen with a lot of pressure. After making sure she understands the difference between bloating and distension, she realized that she did have a lot of abdominal distension, starting in the upper quadrant and bloating as well. So she would usually wake up with the distension, which is also abnormal. And both, so the bloating and the distension would then go get worse throughout the day. Her upper abdomen feels really hard and tense, especially the hypochondriac and epigastric area. And the bloating worsened directly after meals, regardless of content, so with or without carb presence. She has early satiety as well. The gases were pretty smelly and loud, and she has not a lot of control over them, but she does not have any irritation, so no burp for her. Next slide, thank you. In terms of bowel habits, she has diarrhea 1 to 2 times a day, usually with emergency. Bristol 6 to 7, loose, full smelling. The theatera was brown, but the stools were brown and could float from time to time as well, especially after greasy restaurant meal, which can show a difficulty possibly to digest fat here. She has a sensation of incomplete evacuation. So that can also ring a bell here that the abdomen was sensed. She has a sensation of incomplete evacuation. So that's usually symptoms we see in constipation versus diarrhea. So we can already think, okay, is that a diarrhea secondary to a constipation or not? She has so much pain that sometimes it would wake her up during her sleep. And she's had no food residue, no mucus, and no blood currently, but she's had it in the past. In terms of other symptoms, she has the acid reflux pretty much every day and excessive flatulence. So this is for the GI part. And then for extra digestive symptoms, we already talked about it, but she had a lot of brain fog, chronic fatigue, and joint pain, which can also be present sometimes in SIBO cases. It's also important to notice and mention that digestive symptoms are not related to menstruation. Menstruation are regular, and the digestive symptoms do not worsen with the menstruation for her. So when we did the food diary, we saw that the meal times, like she was snacking throughout the day, so the time between meals was insufficient. So it's important to remember that in every digestive cases, we want to have between 3 to 5, usually 4 hours between meals to support the migratory motor complex and support a good digestion. And that was already not the case here. And she would also have a snack way too close to bedtime, which would kind of cancel the 12 hours of fast we tried to achieve at night. We could also notice multiple sources of FODMAP during her meals, her snacks, mostly fructan and galacto-oligosaccharides, and an insufficient total fiber amount, which was to be expected as well, pretty common, about 16 grams a day. In terms of irritants, we had the classic coffee on empty stomach in the morning, 2-3 coffee a day, and 1 to 2 alcohol consumption a day as well. The behavior, she's a pharmacist and she works in a pharmacy. So we can imagine that she's always pretty rushed. So she's eating, standing up at her desk or on a counter, eating on the side between two patients. So she eats pretty fast and also in a stressful environment. So we can also hypothesize that her chewing is probably not appropriate as well. So the first intervention that we wanted to do here is call her MD, call her medical doctor to get a prescription and get tested for SIBO. There was too many red flags in her first 30 minutes of talking with her to think about only IBS, that I wanted to make sure that SIBO or EMO was not present. So that was the first thing. The second goal we did with her was to make sure she optimized her migratory motor complex. So we looked to achieve 4 hours between main meals, and it's fine too if there's 2 hours between the snack and the next meal. So we try to have like 4 hours between breakfast and lunch, and then lunch to the snack, and then to the snack to supper, we can have 2 hours. Then we tried to find a snack that will last her enough so she's not hungry before bedtime, and she could eat 2 to 3 hours before bedtime, so before going horizontal. which is pretty important for reflux, as you know. I won't go into more details for that right now, but it's important to mention that when we ask that for a client that is used to snack every hour, spending 4 hours without eating can be overwhelming and a lot for a lot of people. So it's important to think about the nutritional consideration here and increase protein or fiber content where it's necessary to make sure they are actually satiated for that amount of time. As we have a diarrhea here, we started increasing soluble fiber. We chose psyllium husk because she was already familiar with that we can put in either water or orange juice or any kind of juice. And we already talked about irritants. Going from 2 consumption of alcohol to 0 a day was asking for a lot. So we went for 1 a day and no coffee on empty stomach. Obviously ask as well for a food journal. So 1 week post evaluation, I usually like to see them 1 week after to see if we have any improvements. She did call her doctor, but the appointment is in a month and a half. And that's a long time to live with that much symptoms. It's already been a long time that she's had them, but she's feeling pretty done. She's tired of those. The stools are a little better. She has less urgency, but the bloating and the distension has not changed. So here we decided to reduce her symptoms. So we decided to go with a low FODMAP elimination diet for 4 weeks. Obviously, this kind of diet has to be stopped before we do a SIBO test because you don't want to increase the fermentation before the breath test. So this was just to manage her symptoms until the appointments, and then we'll remove that before the test. So additional help was provided for the client to be able to follow this FODMAP diet, such as menu planning, grocery list, obviously the Monash University app that is always a really good help. And this is the moment when she also shared with me that she was going to give a conference in 2 weeks at a pharmacy conference congress. And she was pretty stressed about, first of all, the fact of having symptoms there because they would be more restaurant, alcohol, and the stress of just presenting for her. And also there probably won't be any low FODMAP options, and she wanted to eat the same thing as her colleagues. So this is where we introduced FODzyme to her. She was really excited about the idea of trying that. So I showed her how to use it, and she ordered hers pretty fast after that. In terms of behaviors, we know that it's as important to look at the what we eat than the how we eat it. So we started talking about taking a bit more time to eat her meals. Obviously, this is not going to change overnight, but it's worth trying to change early on as possible. So there's little tools we can give the clients for them to help them achieve that goal, such as taking smaller bites per forks in order to chew better what there's in their mouth, putting the fork down in between bites, pulls halfway through in order to kind of like check in with your hunger signals as well. So she was pretty stressed about that last goal, but we worked on it. 2 weeks post evaluation. So we're 1 week into the low FODMAP diet, and she's leaving in 1 week for her business trip. So she's pretty efficient. She understands what she has to do pretty well. There's no FODMAP that can be seen in her symptom journal and food journal. The stool consistency is still unchanged. She has less urgency and pain, but they're still present, and the distension as well has not changed. So here we want to make sure that she feels comfortable on her trip. So we talked about protein-rich snack that she can bring in the plane, so she doesn't have to eat the snacks that the plane provides, which are usually not especially good choices in terms of low FODMAP diet. I also added the partially hydrolyzed guar gum, which is such a good supplement for both constipation and diarrhea. It's low FODMAP, and they usually tolerate it pretty well as well. And then we talked about prevention on her trip, so prevention of symptoms. Taking the plane can worsen bloating for pretty much everybody, but it's different because of the elevation. So we talked about that because it's obviously a little worse for somebody that has more fermentation. So we decided to use sodium on the plane ride just in case, and talked about ways to reduce the stress before her conference as well, such as practicing diaphragmatic respiration. It's pretty efficient to reduce to calm the vagus nerve, to calm the nervous system, and so to calm the symptoms. And we also talked about a few yoga positions that have been proven to help with gas excretion. So to do either before and after the plane, in the morning of the conference, and at the end of the conference. So this is really pretty practical and useful tools for the clients. Follow-up number 3, the patient is back home. Fodzan has really helped her. She felt like she actually hasn't felt any anxiety as she was there. She's been able to eat everything she wanted with her colleagues. Obviously, she still had symptoms, but she had way less symptoms, no emergency, less pain. So she was really happy about that. Now her appointment is coming up with the doctor, so we want to make sure that she reintroduces the FODMAPs so we don't risk a fake negative at the test. So here, I didn't choose to reintroduce the FODMAPs as we would usually do, like 1 FODMAP at a time. We test 3 different portions. So what we did was mostly include a FODMAP containing food every day at every meal, according to her tolerance, just to make sure she has some. And then it's important to mention as well that there's a preparation diet for the breath test. Again, not to risk a fake positive here. So before the breath test appointment, 24 to 48 hours before the test, we want to eliminate most high fiber sources. So it's usually plain rice, white rice, barely any vegetables, and like chicken or tofu. So really like a gastro little diet for preparation. This is the results of her breath test. So follow-up number 4, we can see on the diagram on the right that we have a positive for EMO here, so intestinal metanogen overgrowth, rather than SIBO actually. Technically for SIBO, we want an increase of 20 ppm by the 19th minute. And then we can see here that there is an increase about at 28 at 120 minutes, which is technically a little too long to be able to diagnose a SIBO. For EMO though, the diagnostic criteria are at least 10 ppm at any time in the test. So we can see that at the baseline, we started at 34, and we went above around 161 at 160 minutes. So here we technically have only an EMO and not a SIBO, as it does not meet the criteria, the diagnosis criteria. But the doctor, who was actually familiar with the treatment of both, decided to prescribe both just in case. When I say both, I mean that usually we use rifaximin for hydrogen, so for SIBO, as it has an impact that is local and it has an impact on the bacteria. But rifaximin has no impact on the metanogens. So for EMO, rifaximin wouldn't work really well, and that is why metronidazole has been added here. Depending on the amount of gases, also the concentration of the gases, we can go from 15 days to 21 days. That's obviously the decision of the doctor here. So she will start her antibiotics in the next day. So we make sure to include FODMAP containing food during her treatment, as bacteria are easier. It's easier to kill bacteria when she's in replication. And to make sure they are replicating, we need them to be fed. So we needed to have FODMAP containing food in her diet. Then I included a prebiotic in her diet as well, family food, just to make sure we still nourish the good gut bacteria. I usually choose here prebiotics that are not fermentable, such as polyphenols mostly, so spinach, things that are mostly easily consummated and tolerated by patients with intolerance. We talked again about diaphragmatic breathing, the yoga poses, the specific ones that I told you about to release the gases. And the daily walks are also pretty important to support motility. She works in the pharmacy, so she does walk a lot in the pharmacy, but we were talking more of a calm walk outside. We did a quick reminder on the importance to chew food thoroughly as the digestion starts in the mouth, and that if she misses that step, there's going to be fermentation, more fermentation in the small intestine, and probably also symptoms of reflux. We added here S. boulardii, so Saccharomyces boulardii. It has been known to increase the efficiency of rifaximin, so the antibiotic prescribed here, and hydrolyzed raw gum. She already had it, but we also made sure that she still was using it properly. I could have added other supplements that could help, such as the NAC that's been studied a lot. I mean, more recently, or the BioGaia, that is a probiotic that is known to reduce the production of methane. But we didn't want to do too much here. We just wanted to focus on what is the most proven. So that's what we used here. For the die-off syndrome, which is a syndrome that can happen when the bacteria die and release toxin, I do usually more prevention when SIBO, so when the hydrogen concentration is higher, because it's mostly with SIBO that we see more die-off syndrome. It's usually a little less with EMO. So we just went over the basics, stay well hydrated, and it's pretty much that. So 2 weeks into the treatment, we had a worsening of the symptoms the first week, which is to be anticipated. So we have to let them know it's a possibility. But then she started feeling a bit better. In terms of symptoms, we could see that her symptoms would actually occur mostly when actually independently of the content of FODMAP. So with non-FODMAP food, with FODMAP food, she would also have symptoms worse, but she would react either way. With the app we use to track, to do the food journal, to track her food, we realized that some of her meals, she would have about 100 to 115 grams of carbs for like 10, 15 of protein, which could be a lot to process for her. So we chose to do a portion guide here, obviously without any restriction, just for her to understand a bit more the combination of the meals that we're looking for and decrease the fermentation. So that's something we did here, and we asked her to keep on with the food journal to see if that would make a difference. 4 weeks into treatment, so she finished antibiotics almost. We have barely any symptoms. We don't have any more distension. We don't have any more acid reflux, so that's a really big win as well. We still see a bit of hesitation to diversify her food sources. So we worked here on a gradual fiber diversification plan to enhance fiber content, like the total one, and the prebiotic sources as well. So with more details than what you see on the screen, we started with whole grains at lunch and supper. And then the week after, if that was well tolerated, we were to add high fiber vegetables cooked to start with. We'll talk about the crudités a bit later on. I also asked her to contact her pharmacist to discuss the possibility of tapering off the PPIs. In the sense that we know that using antacids can have an impact, like increase the risk of developing SIBO. So if we don't have symptoms anymore, that's worth looking if we can taper them off. And she is a pharmacist, so she's pretty, she wants things to be really methodic. So we wanted actually to confirm that the SIBO EMO was actually dealt with. Usually there's an increase, if there's a significant symptom reduction above 90%, I won't always ask for the client to get tested again because it's a lot of time and money, especially because the metronidazole, so that both antibiotics, so rifaximin and metronidazole, are not always covered by insurance. And if there's symptoms amelioration less than 90%, we can consider it. But in this case, she still wanted to do it, so we did do it. Now we are follow-up number 8, so 3 weeks post treatment. The test came back negative, so we are officially done with the EMO. The treatment has been effective, and we don't need here to have a second round. Some patients will need a second round, and well, that was not the case here. It's still important to mention that in the first year following treatment, the recidive, the relapse is, the chances of a relapse are pretty high. So it's important to remember that SIBO EMO is not especially a condition. It really is a consequence of something else, such as an alteration of the migratory motor complex. So we wanted to make sure that we dealt with everything here to prevent also a relapse. So we talked again about the diaphragmatic breathing techniques. So she was feeling like at home was going well, but at work, she would have a bit more symptoms. We also noticed that at work, the way she dresses, she used to have those really tight jeans, high waist, that cause a lot of abdominal compression. So we just kind of tried to switch them with suit pants and that actually ended up working pretty well for her. So it's important to look at other things that would also for those cases. And we also concluded that at work we would use Podzyme because usually at work she would eat a bit more outside food, so restoration with her colleagues, and she feels like she also eats pretty fast there, but she feels like she reacts to FODMAPs only at work. So that might be because of the way she eats, that might be because she's more stressed. Either way, she kept using Podzyme because that made her feel more comfortable and confident about what she could eat. And finally, the pharmacist agreed to remove the PPIs. So that was also a win. So that was the first case on the dietetic management of SIBO. I tried to fit that in about 25 minutes to make sure we have enough time for the rest of the content. And we'll go over the question at the end. But I hope that brought you a lot of insight for the management of those cases.
Hello. Thank you, Laurie. Now we're going to move on to something that's very near and dear to my heart as a GI RD who's vegan, who also has IBS, talking about the management of these issues in vegetarian and vegan clients, because one of the things that we see quite commonly in our practice is that someone who is vegetarian or vegan, most often vegan, but can happen with vegetarians as well, after they are recommended by their healthcare practitioner to go low FODMAP for their IBS, the second thing that they're told is that they can really no longer be vegan or vegetarian. They are going to have to eat meat in order to get adequate protein on this diet, which actually isn't the case. So we're going to talk about that, and we're going to layer it on top of a couple other very textbook things in our practice. Oh, and I'm going to mute my video instead of, there we go, forward my slides. Okay. So client is 33. She is a lawyer, so a very, long office hours, sedentary, very high stress work environment, classic. Lacto-ovo-vegetarian, so she consumes both dairy and eggs, and she is pregnant. She is at 14 weeks gestation. And her medical history is that she has an IBS-M or mixed diagnosis 2 years ago. She had never seen a dietitian previously. But her symptoms have worsened during her early pregnancy, and she has had long-standing GI issues. So lots of bloating, lots of urgency, abdominal pain, and the classic alternating constipation and diarrhea. The other thing that she experiences are, tendencies towards what some might consider disordered eating. She has significant food fear and dietary restriction. And this is something that's a little bit difficult to tease out in this patient population, because one of the things we have to understand is whether or not her fear of food and aversion and avoidance of certain foods is simply a rational response to the, of course, enhanced symptoms that she experienced upon the act of eating. Our bodies and our minds are always trying to protect us. So when we eat and when it causes significant symptoms, of course, our body is going to say, oh, what did I eat in that meal? And maybe I shouldn't eat that food again, versus more of a classic eating disorder presentation. Here in her history, we do have, as she said in the intake, she wasn't so worried about it before because it would help her manage her weight. So already we have, this, evidence of, potential restricted eating or, vigilance around weight and around food intake. But now, because she is pregnant, she does have a genuine fear of, harming her pregnancy due to the restrictive diet. The other thing that I want to say, which was also reiterated at DW last month in a presentation, is that our typical screening tools for eating disorders and things like the NIAS screen typically overestimates in a GI population, because we do have this very rational, reasonable fear and, of course, food avoidance in an attempt to self-manage symptoms by not eating certain foods. So just something to keep in the back of your mind. High meal-related anxiety, anxiety and IBS go like this. Taking her prenatals, B12, and algae-based DHA. Her BMI is 18.5, and 14 weeks in, she's only gained about a pound since the beginning of pregnancy. And so she is 114 pounds. We've got everything in kilos here, but I will do the pounds for all of my American friends. So she's about 114 pounds at this point. So her GI symptoms, alternating constipation and diarrhea. She can go 3 to 4 days without a bowel movement. She does have a lot of false urges during the week where she feels like she needs to go, but it's actually just gas that passes and no stool. And when she does go, she has a full-on Bristol 7 accompanied by excessive gas. And then the diarrhea can persist for several days with quite a bit of urgency, particularly after consuming coffee. So I know Laurie mentioned this in her presentation as well. Coffee, the caffeine can be a stimulant, but it's not just the caffeine. The chlorogenic acid in coffee is a really potent initiator of the gastrocolic reflex. So, for someone who's typically constipated, that might be a wonderful thing. But if you're experiencing diarrhea with urgency, it is something that is an irritant that you probably just don't want in your life. She occasionally passes mucus, especially after passing the first few stools post-constipation. The GI tract can produce this mucus in an attempt to just help move things and sort of lubricate things along. She does feel that incomplete evacuation sensation, and she does not, also very important in terms of just checking off the list during your intake, she does not notice any significant worsening of symptoms according to her menstrual cycle. So her bloating begins after the very first meal of the day. Also importantly, because bloating is a sensation, distension is the physical change in abdominal size, which is different than bloating. So no to mild distension. She does have mild distension if she hasn't been to the bathroom in a few days, which makes sense because the abdomen is literally filling up with stool. And her bloating does progressively worsen throughout the day. So abdominal pain occurs randomly, but on most days of the week. And it has been ongoing for the past 2 years. So this is where we see that, because that pain is the important factor in diagnosing IBS. And then here is something really interesting in her history, because one of the things that I see in practice often is we really have to sort of tease out, the diagnosis is the diagnosis, but when we're formulating our response or our initial considerations of where are we going to go treatment wise first, is it a true IBS? Or is this person very constipated and now the body is trying to overcompensate? So we have the constipation and then we have the breakthrough diarrhea. And IBS-M can be this. You have this impaction of constipation, all this stool filling up the bowel, and the body is simply trying to get whatever it can out. And she does actually have a history of mild constipation during law school, but there was no abdominal pain at that time. And symptoms have worsened over time. So she finishes law school, goes into her career in a high stress environment. And so that for me, I start to question, well, what is the role of stress in terms of initiating and worsening that visceral hypersensitivity that contributes to the pain that we see in IBS? The other thing that I want to mention, because we're going to talk about dietary recall now, in our practice, one of the top sources of food intolerance type reactions is actually chronic constipation. And it is a highly underestimated source of those sort of food intolerance reactions. And so for this client, we see lots of food avoidance. Some of the classic sort of high trigger FODMAP foods like garlic, onion, legumes, apples. It's eliminated all gluten sources and even most starches. So this is not someone who's even eating a lot of rice, for example. She's eliminated over 15 foods. And as you would expect in that situation, her fiber intake is pretty low. It's roughly 15 grams a day, which is, the average North American. She also doesn't have a lot of dietary diversity because the amount of fear that she has over, well, if I eat this, are my symptoms going to get worse? It starts to sort of shrink the parcel of foods into like a very small amount of quote unquote safe foods. As you might expect, as a vegetarian who is not consuming any legumes, the protein intake is pretty insufficient. So like breakfast, lunch, and dinner, only one of those meals is going to have a decent protein source. Not consuming soy, not consuming legumes. It makes sense because legumes are a source of GOST. So they're very fermenty. They can absolutely cause a lot of symptoms in those who are intolerant to them. And then her meal frequency is also suboptimal. Really high stress job, can be locked in meetings, could be up to 6 hours in between meals. And then snacks are something that are very easy and not messy to just sort of like gobble up. So things like rice crackers. As you would expect, fast eating, often while standing, working, walking in between meetings, and a really sort of like high anxiety, high stress sort of lifestyle. So interventions. First things first, we really need to make sure that she is properly nourished, not only to support her health, but to support the pregnancy itself. We also want to work on reducing that food-related fear and optimize food consistency. We want consistent meal timing, a good variety of foods, also so that she can hopefully begin to enjoy food again. And that's something that I'm really, really passionate about in GI, when so often the idea is restriction, restriction, restriction. The idea that folks have sort of lost the joy of eating is something that we really aim to sort of empower people to understand their triggers, but then also so they can gain back that sort of sense of like joy and interest in eating again. So first things first, ordering FODzyme is a really helpful tool to have in your back pocket, especially for someone who's going to have like a lot of client meetings that are catered, a lot of client dinners where they're not always in control of what is going to be on the menu, just to help reduce some of those FODMAPs and therefore those symptoms. The other thing is adding a protein. One of the wrinkles of plant-based proteins is that they are often going to be high in FODMAPs. The other thing to think about, particularly when we see a dietary pattern that's relatively low in protein, one of the reasons we love protein is because it helps to slow down gastric emptying. It helps slow the rate of digestion and absorption, so that's where we get our balanced blood sugars, all of that kind of good stuff. But when someone already has altered motility and it's sluggish, eating a really high protein diet, or even just increasing protein from a very low protein baseline, can contribute to this sense of sluggishness that can feel a little bit triggering in terms of food reactions. So we really want to make sure that we do that thoughtfully and slowly. The other thing that we really want to encourage, and Laurie has already alluded to this, but I'm going to like double down when it comes to plant proteins, is chewing. Chewing is absolutely critical. That is our only opportunity mechanically to alter the food before all of the chemical digestion and absorption that comes next. So the more thoroughly we chew our foods, and it becomes extra important when we're eating a lot of plant-based foods to help break down those tough cell walls, it's going to help just optimize digestion the whole rest of the way. The other thing that Laurie has also mentioned already is just in a high stress environment, if we are not chewing well enough, if we are hyper stressed in the eating environment, we want to do whatever we can to sort of like get into that rest and digest mode. Sometimes with my clients, it could be as easy as doing what I think a lot of us call box breathing. So that idea, like inhale for 4, hold, exhale for 4, just a few rounds of that to like sort of like deep breaths, get into that rest and digest mode, and then taking our time to eat whatever we can. We also wanted a couple easy wins here. So 2 kiwis a day. I love kiwis for constipation, not only as a fiber source, but also with the actinitin. And we do have research to show that kiwis can be effective in helping improve constipation situations. And then 1 tablespoon of ground flax a day, just to start increasing fiber intake. When we do more fiber, we definitely need to increase the liquid to help the fiber do its job. And then we ask to do a food and symptom journal just so we can start to keep an eye on things. So follow-up, 1 week post-evaluation, FODzyme ordered, has not arrived yet. Weight has not changed. So the patient is starting to feel a little bit more energized, which I would fully expect, one, when we start to correct under fueling, but also correct under protein consumption. We've seen a slight improvement in stool frequency, but we're still like a 6 or a 1. The bloating hasn't really changed. We now see that there's about 12 grams of protein per meal and 5 grams per snack. She's doing 1 snack a day. So we still see that she's not quite meeting those minimums for pregnancy, and we really want to get her there. And she is still 1 week in, very restricted. We do have some high FODMAP sources present, and she's drinking now about 1.5 liters of fluid a day. So we're going to do something which we do in our practice a lot. We see a lot of hyper-restricted, high symptomatic clients with a lot of food fear and aversion. So in that case, I look to like expand the sort of world of safe foods. And one of the ways we do that is by using low FODMAP or gentle FODMAP, because the expectation of symptoms post-consumption can enhance food anxiety and can actually bring on more symptoms. We think a food is going to make us feel bad. Eating that food will make us feel bad. So when we use FODMAP, because we can say low FODMAP foods, they draw less water into the bowel, they are less fermentable. So when we increase our food diversity using low FODMAP foods, the client has a little bit more of a reassurance that these new foods, even though they are new, are going to physiologically be less triggering of their symptoms. And so we did not full low FODMAP, but the idea of like, let's continue with low legumes, let's continue with, no apples, no pears, no stone fruit, but anything that's not on that gentle FODMAP elimination, let's start bringing these foods in. We also wanted to discuss low FODMAP plant-based protein snack options. We really want to hit those minimum protein targets. In the second trimester, it becomes far more critical than first trimester to really get that protein need up to support tissue development. We also do a little daily light walking after meals, at least 5 minutes, just, to help support digestion and motility. Adding psyllium on top of it, nice IBS. It is one of my favorite fibers in practice. So a little bit of psyllium diluted in a cup of water, and then again with the food and symptom journal. All right, so 2 weeks post-evaluation, 1 week into the gentle low FODMAP diet, we do see about a pound of weight gain. FODzyme has arrived, symptom improvement since the reduction of the high FODMAP sources. So we're seeing less bloating, more stable bowel habits, 1 stool every 2 days versus 3 to 4. So that's progress. We have soft butt formed, which we would expect as we're starting to increase those soluble fiber sources. We're going to get more fiber into the stool, more water into the stool. She's still eating the same thing every day because she's anxious, but she is increasing those protein snacks. And she's eating like vegetables. They are a safe food for her. So carrots and cucumber. And she's brought in the white rice, but that's pretty much it. So now we want to work on something that we do a lot as well, which is increase fiber and increase plant diversity. One of the biggest challenges I see in this area is that highly fermentable, high fiber foods tend to exacerbate symptoms in people with IBS, but also with Crohn's, colitis. And so there is a, self-management of symptoms by avoiding those foods. The challenge is when we do that, we lack fiber, we lack diversity, we perpetuate sort of the inflammation and the microbiome derangements by having a low fiber, low plant diversity diet that's just going to perpetuate symptoms. So we work with something called fiber training to help slowly, methodically get that tolerance for fiber. And the way that you can think of it is this, like we wouldn't go to the gym at like never having gone before and immediately pick up 100 pounds and expect to like bench press that, right? Like we're going to start with super, super light weights, build the muscle and gradually increase weight as our strength increases. And it's exactly the same thing with fiber. So over the next 4 days, we start with 1 cup of cooked vegetables. Just like using low FODMAP is a really great sort of safe, low symptom structure to increase diversity. Cooked vegetables as opposed to raw, a little bit of, pre-digestion really helps. So cooked low FODMAP veggies, adding those in should be low symptom, well tolerated. Also, a little bit of olive oil, which can be supportive in constipation situations. And then we add on low FODMAP fiber-rich starches. So this is the millet, the quinoa, the black rice. Again, we're increasing that diversity, but within that low FODMAP framework to get a little bit more fiber and starch into her diet. And then also we're using FODzyme to sort of like test foods that have been avoided. So a little bit of hummus, a little bit of FODzyme. If after all of that increase, she's still doing okay. And then really sort of getting back to that eating mechanics piece, slow eating, chewing, structured meal times, sitting down, taking that deep breath, and then preparing the body for food. Okay, 2 weeks into gentle FODMAP, I feel like I have to go a little faster now. This could be 2 hours. I would love for this to be 2 hours. Okay, so we've gained 2 pounds now, so that's great. So the weight gain is starting to increase. Hummus was great when taken with a FODzyme, which confirms that it is the FODMAP content that is exacerbating these symptoms. We've introduced the cooked vegetables with some new starches. Those are also going very well. Discomfort is about a 5 out of 10. The bloating is less. We're having a bowel movement every second day, Bristol 4, which is absolutely progress. And here she had a flare up on court day. So this really reiterates it's not always just the food. Clients typically come in never thinking, understanding that stress is not great for them, but never thinking that stress itself can be the potent trigger of their symptoms. And they immediately think it's food and immediately go to food elimination. So this was just a really nice teachable moment to say, hey, look at this symptom improvement, and then look at this flare on a really high stress day. And this is where something like gut-directed hypnotherapy, meditation, diaphragmatic breathing, anything to sort of like get you into that, beautiful vagal tone can really be helpful in those situations alongside the nutritional interventions. So we had these techniques to manage the stress-related flares at work. We also chose safe meals. So meals that she knows will not cause symptoms on those days, just to help. She's like, I know this breakfast isn't going to cause me symptoms. This is going to decrease anxiety on those high stress days. And then of course we have FODzyme when she's consuming those meals that she doesn't have control over their content. And then now we're really starting to want to focus on building the gut microbiota. So adding those low FODMAP prebiotic foods, which include polyphenol rich sources, as Laurie mentioned before, just to start to get our healthy baseline and our long-term gut health going. All right, 4 weeks post-evaluation, so 3 weeks into the gentle FODMAP diet, now we're going to start to do reintroductions. The symptoms are well controlled overall now, and there's daily, just in 4 weeks, daily bowel movements, no urgency, except of course the stress question. Energy intake has gotten back to appropriate levels for her second trimester needs, which again, in the second trimester, just to reiterate, it's about 340 calories. And in the third trimester, we want an additional 450 calories. Her weight gain is slow, but it is within range for her pre-pregnancy BMI. So we plan a structured FODMAP reintroduction phase for the next week. Planning of introduction, preparing a grocery list. We are continuing with the use of FODzyme, especially during, those family dinners, those court days, anytime where she has the expectation of a potential flare and or she doesn't have control over her food. And then we talked about what kind of portions. So something I use a lot is the good old fashioned plate method. Works like a hot damn. So, making sure that she's getting adequate fruits and vegetables, a minimum amount of protein, plus the starches, that she does not ignore either one of those, and then adding healthful fats like extra virgin olive oil, like nuts, seeds, to make sure that she has healthy weight gain. So our goal is to, of course, get her to a diverse and nutrient-rich, very plant-forward diet, not just for her own personal health and long-term optimal gut health, but also for the health of her pregnancy and her fetal development. And then once we understand where her tolerance lies, then we can start to customize FODMAP inclusion for the long term and really help empower her to have confidence around food. Great example is when we don't know which foods are causing us symptoms, every meal feels like a potential landmine. But when we're able to say, actually, I know fructans are a really big issue for me. And so on a high stress day, I might avoid fructans, or I might use something like FODzyme to help me manage that fructan intolerance so that I can minimize symptoms. It puts the client back in the driver's seat because she understands how food affects her body and she can make choices accordingly. All right, follow-up 5, 3 weeks post reintroduction. Her IBS symptoms are actually minimal, which again, as I mentioned, right at the top, if we consider that constipation is probably the primary in the development of these symptoms, and we look to the constipation first, oftentimes many of these symptoms do seem to improve, including the pain. We also understand the tolerance for fructans and onions, garlics, and sorbitol. She is now eating a more diverse, liberalized vegetarian diet. She now realizes that she can tolerate some firm tofu, but needs FODzyme for using TVP, probably because the GOS intolerance is still there. She's practicing, again, this very empowered, proactive symptom prevention, having a calm meal routine, diaphragmatic breathing before meals, takes the time, sit and eat and take a break from work. She's also improved her sleep hygiene so that she can be better rested. And then for late pregnancy, she's planning to cook some well-tolerated meals with her husband to freeze to be ready for baby's arrival. Continued FODzyme use with high FODMAP snacks and dinners. She's established a postpartum meal plan template to support her fiber, iron, calcium, and protein needs. And then we're just looking at what's really easy to digest, high energy postpartum snack ideas, and where we always want to get to. It's always the goal. Sometimes it does not happen this quickly, but feeling in control of her gut again. Great. So in conclusion, in the first case, FODzyme was used as a supportive tool to reduce symptoms and alleviate food-related anxiety outside of the client's routine, such as traveling. And in the second case, we used it to increase dietary diversity in a critical context where someone was experiencing significant food-related anxiety. All right, so I think our reference is there. All right, I think we have a few minutes for questions.
That was amazing. So insightful. Thank you both. Yes, we've got a ton of great questions here. We'll take about 5 to 10 minutes, everyone, for as many of these as we can. Starting with a couple questions from our first case. We've got some questions around the dose for psyllium husk. So what dosing would you recommend, Laurie?
I usually start pretty low to make sure they tolerate it. Like 5 grams is usually my go-to, but I could go at 2.5 if I feel like the client might not tolerate it. And you can go up to 10 grams a day. I usually don't go above that.
Great, thank you. We've got a lot of interest in the yoga positions to release gas. So if you could
Yeah,
point folks to any resources on that or sites where they're
sure.
looking at more information.
I don't know if I think we found that in more research, so it might be listed in the references. I don't especially have another resource where we could find that, but I can list them pretty fast. We have the knees to the chest, the happy baby, I actually have them here, the child's pose, gallant's pose, and the seated spinal twist. In terms of data on that, it's easily findable on the internet, or we can also just try it when we're bloated, and it's pretty efficient.
Great, thank you. A couple questions here on this topic of the low FODMAP diet prior to the SIBO testing and the relationship there.
So, to the fact that we have to stop the low FODMAP diet before?
Yeah, could you explain, I think, the thing
Yeah.
and why we would.
Yeah, of course. So basically, when we remove or lower the FODMAP amount of a client's diet, the goal is to reduce fermentation. So the risk is that if the patient is low FODMAP when they pass the test, that could ensure that could impact the bacterial activity, and so the producing of the gas, and there might not even be enough gas for accurate detection. Kind of like the idea of eating gluten when we do a celiac test.
Great, thank you. Here from Beth, we have a question around the Saccharomyces boulardii probiotic. Since it's a yeast, shouldn't it theoretically not impact antibiotics, but wouldn't you still avoid any prebiotic or probiotic treatment during a time of SIBO treatment? Sorry, I butchered that.
I wouldn't, nothing answers the question. I wouldn't add another probiotic like bacteria during the treatments, neither before if I actually suspect a SIBO, but indeed, S. boulardii Saccharomyces is a yeast, usually really well tolerated and is not impacted by the antibiotics. So I'm not scared of using it at this moment. Just in case, I would just put 2 hours between the consumption of antibiotics and the yeast itself.
Great. And just to follow up on that as well, is the suggestion that it's going to increase the effectiveness of rifaximin? Is there research on that? Is that more based on your clinical experience?
No, there's research on that. I'm pretty sure it's in the references, but if not, it's easily findable on PubMed, or I can also forward the study to whomever is asking.
Great, thank you. And then here from Christina, how do you handle pushback from physicians that say the breath tests aren't always accurate?
This is a tricky question. It's putting me on the spot. Um, it's not always easy. There's a lot of physicians that don't believe it exists or it's a thing. Some even say it's a trendy disease, which is not. So how do I handle that? I really stay as professional as I can with a client, not showing deception, not criticizing the professional, not for them to lose any faith in the system. I usually will contact the doctor if I can, either by a fax, an email, or a call. If there's no opening whatsoever, we might try to find another opinion, so another doctor that might be open to it. And if we don't have any choices, that complicates the treatment because we cannot have antibiotics. There's always other options we can try, but those are less by the guidelines, and I'd rather stick to the antibiotics.
Yeah.
When I can.
Here, and then last question for you, and then we'll move over to Desiree's case. Would you discuss die-off syndrome further?
Yeah, so die-off syndrome is basically the worsening of the symptoms. Usually lasts from 2 to 4 days, sometimes more if the symptoms are if the gases are really high. And it's the symptoms caused by the toxins that the bacteria are going to release as they die. So it's the body of handling those toxins. The body responds to handle those toxins. Sometimes there's not a lot of research on that diet syndrome, but it sounds like when people have a lot of inflammation or a lot like inflammatory condition or autoimmune condition, they have more symptoms. If they're less active, so the more active you are, I found the less symptoms you have as well. And it does not reflect the efficacy of treatment as well. Some people just don't have any diet syndrome. It does not mean the treatment is not working.
Thank you. Very interesting. Here, so moving on to our second case, Desiree, if you could help folks, help clients differentiate between symptoms of bloating and abdominal distension.
Yeah. So, it seems like, because people are like, well, bloating, distension, what is it? Bloating is a sensation. So bloating you're like, I just feel bloated. I feel full. I feel expanded. But distension is the actual physical change. So bloating can occur with no change to the abdominal measurement whatsoever. Distension is change to the abdominal measurement itself. So there's a physical enlarging of the abdominal cavity.
Thank you. Great. Here we've got a question from Melissa. Do vegetarian vegan eaters always need supplemental enzymes like a FODzyme when eating plant-based proteins and legumes?
Not necessarily. So, we were talking specifically here with a case that I suspected was always really about the constipation. And so, as I mentioned, that constipation is a primary driver of those sort of intolerance type reactions when we eat highly fermentable foods, but like there's a backup that like gas is not moving clearly through the symptom. FODzyme can be really helpful, and low FODMAP can be helpful simply to minimize that as we're working on the constipation, sort of as we saw in the other case. But maybe the FODMAP intolerance isn't truly there once we sort of get things moving and once we build up our tolerance. However, for someone like great example, so I have an intolerance to fructans and GOS, and I am completely vegan and I eat these things every single day. What people will often find is what they're feeling well. We have this sort of like old adage in nutrition, like eat well when well. When people are feeling well, they may be able to consume like a reasonable amount of these foods, but say they layer on stress on top of that, and they know that stress is also an additional trigger so that they're going to be less tolerant of these FODMAPs. That's when we can like say, okay, well, so you have the FODzyme there to be your like backup. You're like, I'm just not feeling great today, but I am also going to eat a lentil salad today. So it's like FODzyme, which is also how I personally consume it in my practice. So no, it's not that folks with IBS will always need to take enzymes. If the FODMAP intolerance is there and it's always there, that might be something that is more regular for them. But I actually find in vegetarian and vegans, that is often not the case. When we work on symptoms, when we work on visceral hypersensitivity, like again, I cannot say enough good things about gut-directed hypnotherapy for managing that sort of like brain-gut connection to the visceral hypersensitivity. But also other dietary strategies. A really great example is I see often in vegetarians and vegans, this sort of like I call it a high dry goods diet, where they eat like a lot of legumes, a lot of grains, but not a lot of like fresh fruits and vegetables, for example. And when in those people, I find just practice-based evidence, when I shift them to a more high fruit and vegetable diet, their tolerance of everything seems to improve too. So no, it is very individualized. And I do not agree that like everyone's always going to need enzymes simply to handle like the typical sort of like FODMAP concentration of their diet.
Great. Yeah. Thank you so much. Yeah, fascinating. Here from Heather, we have a more counseling-based question. So do you create kind of detailed meal plans for your clients or have them lead the way in creating their own meal templates?
Yeah. So I feel like so many dietitians, we all have our personal preferences. I don't like meal plans. I don't like them because if the client is relying on me to tell them what to eat, It eliminates their agency in choosing what to eat, but also their skill. My goal is always to get folks to a very intuitive place with their eating. It's like, how am I feeling right now? Therefore, I'm feeling really great. I can probably push it on these foods that maybe I have more of an intolerance to, like the lentil salad, versus I'm not feeling great right now. So maybe I'm going to lean on a more low FODMAP meal for dinner because I'm just feeling a little extra bloated today. And so, what I typically do, again, very like patient centered care, depending on the client, if they're like, I work 70 hours a week. I don't have time to think about what I eat. What I will often do is I will say, okay, so what are the typical things you eat for breakfast? They might be like, oh, I really love a smoothie, or like I love a cafe sandwich. And I'll help pull, like, here's 3 recipes that are going to work for you. So if you like that smoothie, here's a low FODMAP smoothie. If you like that sandwich, here's a way of making a little cafe sandwich that'll work for you. And I'll give them specific recipes and teach them why I've chosen those recipes, with the idea that once they sort of get into this rhythm, they don't have to think about what they can eat, that they're starting to learn the tasks and tools. We're like, well, I don't want to eat these 3 breakfasts again, that they can figure out a new breakfast to eat on their own, to sort of like put that agency back on them.
Great, excellent. Thank you. And here for our last question, which admittedly could be a whole webinar in itself, a brief overview, if you could provide one, on gentle FODMAP.
Yes. Okay. So first things first, something that I didn't talk to, but it was in the footnotes if you saw it on the slide. Low FODMAP diet is not appropriate in pregnancy. Restrictive diets are not appropriate in pregnancy, but also for people with histories of disordered eating. So the idea of layering on this very complex, it's very easy to be gluten-free. And I think that's why so many people take to it. You're like, I get it. I just don't eat gluten now. But low FODMAP is like, oh, which vegetables in which amounts, which grains in which amounts. So it can be whether or not it's not appropriate because of their medical history or current needs, or whether it's deemed too complicated for them. A really interesting option is gentle FODMAP, where we're not giving this giant list of foods. It's just the avoidance of sort of like some like high value triggers. So a great example is wheat and rye. That's going to be a major fructan source. The allium, so garlic, onions, a major fructan source. We're also going to eliminate legumes, major GOS source. We're going to do apples, pears, stone fruits, watermelon. What am I missing? I always miss a couple. So dairy, of course, the vegan forgets the dairy. So milk and yogurt, so the higher lactose, and then cauliflower and mushrooms. Those are the last 2. So that's it. The elimination is simply that. All other things are on the table. So it's a far smaller portion of foods to sort of keep in mind. You're like, oh yeah, no cauliflower, no mushrooms, no wheat, as opposed to like sort of like doing the mental math on the full low FODMAP. So it can be really helpful just because it's like a lower like cognitive burden than the lower FODMAP diet, but then it's also less restrictive, which is important in a lot of different patient cases. Yeah. Oh, and also the research supports it. Most important thing, the research supports that gentle FODMAP is actually maybe like a really good place to start for almost everyone, as opposed to making them go fully low FODMAP. Yeah.
Great. Well, thank you for that, for this whole presentation, both of you. That was so fantastic.